Hi, my name is Pia Tuominen, and I'm here today again with Professor John Reid. You're the Professor of Clinical Psychology at the University of East London and the Chair of International Institute for Psychiatric Drug Withdrawal. And I'm a former psychiatric patient, and I like to use, for example, my podcast to challenge the mainstream views of psychiatry. And this is our sixth episode together. I'm glad to be here with you, John, again. And this is part of our series, Challenging the Medical Model of Mental Health, a call for humane, evidence-based services that respect human rights. And today our topic is psychosis. And I thought I'd start by sharing a bit about why I wanted to include this topic to this series, even though we already talked about these so-called antipsychotics. This is such an important topic to handle separately, in my opinion, because there are some people who might think that, sure, we can perhaps treat anxiety or depression with no medications or with some different approaches, but there's some people who seem to think that psychosis is very different, that we have to definitely look at it in this pathologizing way, that it's an illness that we have to treat with medical experts and have medications for that. So I think this deserves a separate episode, because we have to talk about the alternatives, the different ways to look at psychosis and what these extreme states or different states of mind can be, how we can approach them differently. And especially when we talk about these diagnoses, for example, schizophrenia, they are such often a challenging topic to talk about, because people have so many beliefs about them that are not necessarily as scientific as they believe. So I thought that as a starting point, could you perhaps share a bit about this diagnosis of schizophrenia? And what is the basis of that, scientifically? What should we know about that? Because that's one of the most extreme diagnoses that is out there in the within psychiatry.
Okay, good to be with you again, Pia. So, and this is a topic close to my heart because it's when I was a practicing clinical psychologist, most of my work was with people who experience psychosis. I was always more interested in that than anxiety and depression. Not because anxiety and depression is unimportant, but I just always found people who hear voices or think the world is out to get them just actually quite fascinating. I mean, I don't understand why everybody isn't fascinated in the notion of hearing voices when there isn't anybody there. It is quite fascinating. So clinically, and then my research also is mostly in this area. So, but the concept of schizophrenia is first of all really completely unscientific and extremely damaging in terms of stigma and creating pessimism about the chances of recovery. And it's a word we really ought to stop using. And in fact, some organizations, Japan, for instance, has gotten rid of the term completely, and one or two other countries. And the organization that I belong to, the International Society for Psychological and Social Approaches to Psychosis, used to be called, used to have schizophrenia in its name, and about 10, 12 years ago, we voted to get rid of it because of the lack of science and the stigmatizing effect. So in terms of the science, what actually happened was, at the end of the 19th century, psychiatry had really not come up with anything for the whole century, whereas real medicine, science, that's a bit extreme to put it that way, but we'll say other branches of medicine it was a century of major successes, identifying real illnesses with demonstrable biological causes. Psychiatry had failed to come up with anything, and to the last decade of that century, a guy called Emil Kraepelin literally just invented a new illness. He said he discovered it, of course, but what he did was just lump together. By the end, it was hundreds of different types of behaviors and thoughts and feelings, and called them something. The term was actually dementia praecox, which is the early version of schizophrenia. That the word schizophrenia came in about 1911 when Bloiler renamed the illness, but the illness was still invented by Kraepelin and called dementia praecox. And by the fifth edition of his his textbook, there were over 100 pages describing this thing he did. I'm just going to read a couple because it's quite illustrative. That's all right, Pia.
Mm-hmm.
These patients conduct themselves in a free and easy way. They laugh on serious occasions, and they go about in untidy and dirty clothes, and they go with a lighted cigar into church. The loss of taste often makes itself felt in their choice of extraordinary combinations of colour and peculiar forms. The want of a feeling of shame expresses itself in regardless uncovering of their persons. Patients are in love with a ward mate with complete disregard of sex, ugliness, or even repulsiveness. So it goes on and on. Looking back, it's clearly just a list of broken social norms. And within that, there are things like hearing voices and being paranoid, but most of it is just a list of broken social norms listed together and with a name applied. Both Kreplin and Bloyle, the guy who first used schizophrenia, were very clear, they're very honest to admit that they had no idea what the causes were, no evidence that it was a biological phenomenon. They just said it was. And then they said, to be discovered later, which is a very, very good, very good way to deal with the fact that you haven't got any evidence. So just trust us, we'll find it later. And in fact, the geneticists are still looking 100 years later and haven't really found anything of significance. So that was the origin of it. And if we weren't still using this word 120 years later, it would just be an interesting blip in history. But unsurprisingly, when we started, just in terms of the science of it, when people started really looking at the reliability and validity of this construct, reliability being can people agree on who's got it, and validity meaning is it what the theorists say it is, there is really very little reliability or validity. So the levels of agreement between psychiatrists on who has and hasn't got schizophrenia are quite minimal. And yet it's a very, very powerful word. Some people genuinely think it has some sort of explanatory value where it's just a label, because the argument is, here's somebody with schizophrenia. How do you know they've got schizophrenia? Well, they're doing the sorts of things that people with schizophrenia do, which is backwards circular logic. It doesn't, and then they think, not only, they then go on to sort of assume it's a cause. So like the reason people hear voices or think the world is out to get them is because they have this thing inside them. We can't demonstrate it, we can't find it, we can't show it to you, but it's this word that is supposed to cause these things. And it's just a word, it's just a construct. And it's also a construct that has very little reliability or validity. So I'll finish by just quickly pointing out, today, our best attempts to define it in the Diagnostic and Statistical Manual, they list 5 types of symptoms. Doesn't matter what they are for the sake of this point, but you only need 2 of them to get the diagnosis. So you, Pia, might have symptom A and B and none of the others. I might have symptom C and D and none of the others. We have nothing in common, but we have the same diagnosis. Mm-hmm. This is called a disjunctive category in science, and the layperson for that is just nonsense. The ordinary, it just doesn't mean anything. So I do get on a bit of a rant about this, but it's important to remember every time anybody uses the word schizophrenia in a clinical or a research setting, they are actually talking nonsense, because there is no such thing. I have to add, and then I'll shut up for a minute, I have to add, when I say there's no such thing, I am not saying that people don't experience voices that can be very scary, and that full-blown paranoia isn't very scary. Of course, people have those experiences. I'm saying that applying this word to those experiences and thinking that you've explained anything is just not true. And that's before you go on to the stigma of the word, because the implications are you've got this thing. It's not only have you got it, but it's permanent. There's something permanently wrong with your genes or your brain. And so, surprise, surprise, a lot of people don't get better after being told that. But that, of course, is the nature of the illness, not the self-fulfilling prophecy of a very powerful person telling you that you're never going to get better. But you might get a little bit under control if you take the medication for the rest of your life, but you'll never get better. So yeah, I think if we're going to talk about psychosis, we just have to take this thing called schizophrenia, call it what it is, and throw it away. Then we can have a discussion about people who hear voices, people who get very paranoid, and it can be a meaningful discussion. So I just need to get that off my chest. So.
Yeah, that's good and such an important thing. And to refer back to our previous episode, we talked about the some of the effects of the so-called antipsychotics, which actually aren't antipsychosis. Just to clarify that to our viewers who may not have been like watched that episode yet. But we talked about also how the effects of this treatment in quotation marks can basically cause people to think that they have this thing called schizophrenia as well. So the effects of our treatments are part of what can be viewed as symptoms. So that's one of the big issues that I have with psychiatry in general. That so often that we can, through these disorder lenses, we can interpret very many things as being symptoms of illness and not recognize what's going on, and what can be like other ways to look at those symptoms, so-called symptoms, if we want to look at it that way. But what do you think? What are the most common misconceptions about psychosis in general?
Well, that it is some. Psychosis is obviously a broader term than schizophrenia or any specific other disorder, and it's. I mean, the consensus around the term psychosis that it basically involves loss of contact with reality, one way or another. So, hearing or seeing things when there isn't actually anything there, or believing that people are out to get you when they're actually not out to get you. So that's very broadly the definition of it. The myths are that as we've just covered, that this is caused by that it's some sort of mental illness with some sort of biological basis. Another myth is that if you do hear voices or get paranoid, that's a permanent state of affairs rather than just a passing thing that may or may not come back from time to time. And the other myths are that there's a genetic base to it, that there's a biochemical imbalance, the dopamine theory, which has no basis in reality. Well, it does, but it's caused by the medication. We may or may not come back to that. So people who aren't on the medication do not have a dopamine imbalance. Other myths, I guess the big one is that people who are psychotic are dangerous. The old image of the mad axe wielding murderer, which is well ingrained via films and all sorts. There is a grain of truth to in two types of circumstances, people with psychosis diagnosis are somewhat more likely to be violent, and the two circumstances are if they're heavily involved in drugs, street drugs, but then that's true of everybody. And also when they're confronted with coercion from the mental health system. People sometimes, understandably, not excusably, but understandably, can become very violent when people come knocking on their door to drag them into hospital, or when nurses and security staff in a hospital jump on them, hold them to the ground, and forcibly inject them. People understandably become violent in those circumstances. So there's some truth to people's diagnosis being more violent, but they're 20 times more likely to be the victim of violent crime, than to commit violent crime. So those are some of the major myths. I'm sure there's other ones.
Yeah. Some of the things that I can think about, like hearing from people who have this kind of diagnosis, some kind of psychosis diagnosis, and they've been told, for example, that it's progressive, that they need the treatment the experts are given because it is progressive, and the other one that like this psychotic state is toxic for the brain. These are some of the things that I've heard people being told about these like, sure, there are severe problems that they have in their lives at the moment when they are experiencing these kinds of things, but to be told that they are progressive and that they are toxic to the brain, and I don't think we have like any evidence on that, and we may actually again see the effects of the treatments long term. for people to say that.
It's very difficult to get good evidence, as you say, that these are neurodegenerative illnesses, because 99% of people are on the medication, and we know the medication reduces brain volume and all sorts of other things. So it's very hard to, as you say, to separate that out. There isn't really any good evidence that it's a neurodegenerative disease. That's one of the drug company myths that have been used to sell the idea that there's an urgency to getting people on this medication, because if you wait, the brain is somehow rotting away, or some terrible image that they can conjure up, which is very irresponsible. Because that's quite a frightening thing to be told. And not only is there something wrong with your brain, but it's getting worse day by day. That's a very irresponsible thing to tell people without any evidence.
Yeah. And as I mentioned before, I had the schizoaffective disorder diagnosis, and I was at one point told that these cognitive issues that I had and these so-called negative symptoms were part of my illness, and then they disappeared when I withdrew from the medications. So that's like one of the big issues I think we have, that we are not able to see the person basically as they are without the effects of the medications, especially after long-term use. And even thinking about this word schizophrenia, we have ex-patients, former patients, who have let go of that diagnosis and are doing fine in this world. So I think we have to really think about, like, what does it tell us that we have people who have had this diagnosis and have one way or another found their way out of the psychiatric care and are doing better now. Like it doesn't make sense if we have this thing called schizophrenia, and that it's this long-term, like rest of your life thing that you have to bear with you for the rest of your life. So we have really big issues here to so that we could better help people who are experiencing these kinds of extreme states, but not make it their destiny when it doesn't need to be. And that's one of the main issues I have with psychiatric care today, and why I'm very excited to have this series to challenge the medical model, because I think it's doing a disservice to people, like a very, very big disservice. And one of the thoughts that came to my mind as you were talking about the situations where people are coerced and like forced treatment and being injected forcefully, this idea of control, that we need to control these people, this idea that we need to control these people. And these are people who have previously often have traumatic experiences. And I'm just thinking to myself, like, how can the mental health system not see that they may be continuing the traumatic experiences these persons have faced before? Like it's basically the same coercion, because there's so much like experiences of abuse or like neglect, sexual abuse, and like very traumatic things. And then they are forced, they are coerced, they are not being heard, and they are told that their symptoms are basically meaningless. They're just part of this illness. And when you mentioned about this like loss of contact with reality, like I often wonder how much loss of contact with reality is there within the mental health care system.
Okay, and before we get into the coercion and the re-traumatization, I just wanted to go back briefly onto the outcomes issue. The points you're making now are really important, because we have to get rid of this pessimistic idea that people can't recover. And on that topic, I just got back from, as I mentioned to you before we came on, from Switzerland, where we had the International Society for Psychological and Social Approaches to Psychosis had a big conference, and two of the people who had studied people with a diagnosis of schizophrenia the longest, 30-year follow-ups, Luke Jumpy and Courtney Harding, presented their data. It's not new data, but they reminded us of the extreme variation in outcomes. There's no pattern to it, and it's also very hard to predict. There are some predictors. Women tend to recover a little more often and faster than men, but most of the predictors are in the social domain. But the important thing is that there's just huge variation. And the other thing to add is that back in the 80s, the World Health Organization did some huge studies comparing what then called the developed countries versus developing countries, like developing meaning South America, Africa, and India. And their average recovery rate was about 2/3. The average recovery rate in Europe and the United States was about 1/3. Now, since then, we spent a lot of time trying to convert those countries to the medical model. So I don't know if it would be the same. But at that point, when those developing countries had very little access to psychiatric diagnosis or drugs, people were recovering there at twice the rate as places that had all the sophisticated diagnosis and medications and so. So it's actually quite outrageous that the global mental health movement, as it calls itself, is sending experts out to these countries to teach them the medical model and to discredit their local healing practices. Because I thought we'd understood that colonization is not a good idea, but psychiatry is still doing it. So that was just important to stress really strong data showing the variability of outcomes. Many people recover completely. Some get stuck and are stuck with frightening voices for long periods of time. And then there's lots of people in between those two extremes. So just wanted to say there's good data to support the point you were making. In terms of coercion, re-traumatization, yes. No, I don't think our mental health services understand how often we're re-traumatizing people. And the reason I think that's the case is that we know that most of the time people in the mental health system are not even being asked about adverse events, especially childhood trauma, child abuse, child neglect, and so forth. Obviously there's variability, but our studies that we have published a review of the studies looking at that, and most people are never asked. Some people are. So when nursing staff or security people are jumping on people and forcibly injecting them, which actually does involve removing their trousers or or the dress or whatever, because the injection is into the bottom. So you couldn't be more re-traumatizing than that if you were sexually abused or as a child or raped as an adult. But they don't know that because they don't know the person's history. That's not an excuse. I mean, obviously, but that's just a thought. Obviously, they don't know they're doing it. So, yes, the whole issue of coercion is a huge one. I don't, and it's not a clear-cut issue for me, because some people, as we mentioned, some people under certain circumstances who have a diagnosis, a psychotic type diagnosis, can become violent, or and they certainly have a higher rate of trying to kill themselves than other people. So sometimes coercion seems necessary. I think a lot of it could be avoided if we learned how to connect to people better, how we learn to identify what triggers people and avoid doing that. But even with all of that, sometimes, I mean, if someone is saying, I'm going to go home from here and kill my mother, you have to take that seriously and make sure they don't go home and kill them. And we have given that responsibility to psychiatrists. And of course, they're in a difficult situation, because if they don't do anything and the person then goes home and is one, they're the ones that get in trouble. So I just think the vast majority of coercion could be avoided if we had more, and that has actually been demonstrated, where taught nurses de-escalation skills and how to calm people down and how to avoid provoking people in the first place. A lot of it can be avoided, but I think not all of it. Whether that justifies compulsory medication is a different issue. I think compulsorily sort of perhaps detaining people or restraining people so that they can't kill themselves or kill somebody else, I think that is justifiable in some circumstances. I'm not sure that the idea of then compulsorily medicating them, because there's no evidence that that actually reduces them. I mean, if you can tranquilize somebody so that in the short term they haven't got the energy to do anything, but it doesn't do anything in the long term to prevent that person feeling so angry they want to hurt themselves or somebody else. Sorry, it was a bit of a ramble there.
I wanted to mention that to prepare for this episode, I read the Models of Madness. Like I haven't read it all the way through, but it's I think it's a very good compilation of different approaches to psychosis than this only this like biomedical model. And there are a couple of things that I'd like to bring up from that book.
I'm just going to hold it up. I don't usually do this, but there you go.
Yeah, it's a very good book, and I highly recommend it for our viewers to get that book in their hands and to read it. But there's a couple of quotes I took from there. This is from the chapter Understanding Psychotic Symptoms, Cognitive and Integrative Models by Richard Pendle. And there's this like talking about hallucinations and these psychotic symptoms. I took this quote for my notes. It appears that many people experience hallucinations often over long periods without feeling the need to seek psychiatric help. And that they can be more common than we think. And this is one of the things that I really think people need to know, that these kinds of experiences can be more common than we perhaps assume, and that they can be within like normal variation of like human experiences. And I think that's one of the issues I have with this medical model, that we are so quick to label them as illness, when actually there are people who are like living fine with these kind of hallucinations. For example, the auditory hallucinations, hearing voices. And Hearing Voices Network is, I think, a good example of a place where people could go to seek different kind of understanding about hearing voices.
Indeed. When you look at the surveys that have been done around the world on of the general population in different countries, of how many people have heard voices at some point in their life, it's about 10-12%. Yet only 1% of people end up with a diagnosis like schizophrenia and psychosis. So what makes the difference between the 1% and everybody else who hears voices sometimes and is just fine, or maybe they're not perfectly fine, they're a bit worried by it, but they get on with their lives or whatever. And we have some research on that. One of the main determinants of whether someone who hears voices ends up in the mental health system and is considered schizophrenic or not is, unsurprisingly, how they respond, how they understand it the first time they hear voices, and how anxious it makes them. And if they tell themselves, "Oh my God, this means I'm a schizophrenic, or I'm mentally ill, or I'm permanently different from everybody, or inferior, or whatever," that surprise increases their anxiety. It also increases the likelihood of the voices continuing and the voices becoming bad, because not all voices are bad. Some can be quite good to start with, and most people hear some good and some bad voices. Just to throw that out as well. So yeah, there's a vast majority of people who hear voices just live with it one way or another, and that's just within Western cultures. And again, the majority South, or whatever the right term is these days, people very often just assume that voices are a part of life. I'll use Maori as an example because that's something I know something about. I was in New Zealand for 20 years. And I had a Maori PhD student and who interviewed lots of Maori people about their understanding of psychosis. And I asked her, would you include the question, what causes voices? And she didn't want to do that. She said that, no, I don't want to do that. And then in the end she did, just to keep me happy, I think. She came back with a big grin on her face 2 years later saying, they didn't understand the question, John. And she comes up with this great quote, like, asking me what causes voices is like asking me why the sun comes up in the morning. Because it's just a part of life for probably crudely about half of the cultures on the planet. It's only sort of in Western or European and American, North American that have turned this phenomena into an illness. I mean, many cultures, some cultures, people who have voices are revered as people who have experiences that other people can't access, and people are turned to them for guidance and so forth. And not all the Maori people, not all the voices are good. They're very often interpreted as messages from dead grandparents, sometimes supportive, but sometimes telling them off. No, don't do that. That's, stop that. That's bad. So it's not all great, but and I personally, I don't think dead grandparents can speak to people, but so what? It doesn't matter what I think. And with those understandings, Maori, when somebody went what we would call psychotic, their response is to get everybody, perhaps we'll come on to this when we talk about treatment, but get everybody together, as many people as possible, to figure out what do we need to do as a group of people to help this person if the voices are causing them trouble. Anyway, most people who hear voices. One last thing. There's a couple of studies which are quite interesting. People my age, 60 or above, there's 2 studies showing that if people 60 or above lose their lifetime partner, 80% of those people will hear or see that dead person in the next year. So that leads to the question, what's wrong with the other 20% who can't? So we have turned an understandable phenomena into a symptom of a frightening illness, and that very often becomes a self-fulfilling prophecy.
Yeah, that's one of the things that I'm worried about when people hear voices, that they can have they can make sense in the context of their earlier experiences, for example, that they can identify like whose voice is it or where is it coming from, basically, like voice of abuser, for example. I'd like to call our current way of understanding humans a bit delusional. Thinking about that this don't make sense. Like, it doesn't make sense that people have some kind of hallucinations, or that they are just like, for example, if people understand that they have had bad experiences before, like traumatic experiences, even then they can explain, like this mental health professionals can explain that, but like it's just unfortunate that they happen to get this illness. It's like somehow separate from the experiences. It's not like this. It's kind of a coincidence. Like, sure, they had traumatic childhood, but it's just unfortunate reality that they now have this illness, and we can't do anything about it except like treat the illness. And even this, when people do have hallucinations or delusions or like whatever difficult symptoms, it's so often not encouraged to find out anything about them. It's like those are like off topic, like we can't talk about those, or we're not interested in those. And previously I've talked with Jaakko Seikkula, like one of the key persons developing the open dialogue approach, and it's very different, because they are specifically asking about like that's something that I haven't experienced. I don't understand what you mean by like you being able to control your neighbor's thoughts or something like that. They ask about the experiences, and Jaakko specifically mentioned that they do make sense. like they, even when they are like wrapped in this symbolic language or some kind of weird to understand experiences, they do make sense when you start to dig in. And for example, I remember hearing him share this example of a young man who wasn't psychotic when they met, but in the discussion, when this topic of his father was approached, he started to experience psychosis at that point. And it became clear that this was a topic that wasn't allowed to be talked about in a way. There was things about his dad that weren't allowed to speak about in his family. So it became this kind of a, like, he started to experience these psychotic symptoms when this topic came up. It did make sense in that context. So that's one of the things that are like very, very much bothers me, that we are thinking that there's such as like some kind of accidental or incidental or unfortunate happenings, like they are separate from this reality, when actually, well, at least I see them as a kind of a continuum or continuation from the earlier experiences.
Very often they are. And and we know that from research, I'll come back to that, but there's an arrogance, I feel, in not being interested in the life of the person you're trying to help. I don't understand. I don't like that we have the most powerful profession in the mental health field. It's only a small percentage of the people, but it's got a lot of the power that mostly is not very interested in what's going on in people's lives. How on earth you're supposed to help somebody with their distress if you're not interested in where the distress is coming from? And that's why very often they're not able to help. All they know to do is to prescribe some pills, which might calm somebody down in the short term, but certainly doesn't address any of the issues. You'll know, Peter, that most of my research is around trauma and psychosis over the years, and we have published many studies, including big meta-analyses of all the studies ever been done, and it's undeniably true that childhood events like child abuse, child neglect, whether it's emotional neglect or physical neglect or sexual abuse, physical abuse, bullying at school, all of those things are very strongly causative of psychosis and hearing voices. And the public knows that. The surveys all over the world, except for America, but it's my bad joke now, they get everything wrong. But in 22 other countries, you ask the public what causes psychosis or schizophrenia or hearing voices, and they all say bad things happening: stress at work, stress at home, loneliness, poverty, abuse, rape, war. People know this. They know that bad things happen, and that's what drives us crazy. It's only one part of one profession, and the drug companies are promoting this other idea. If I may, we did recently a study, because we did lots of numbers, and recently we did just a survey of several hundred people on antipsychotics and just asked them the open question: what do you think caused the problems for which you ended up on antipsychotics? And this was 700 people. They were 13 times more likely to identify a social cause than a biological. I mean, some did both, but 13 times more likely. And I just read some of the quote, because the numbers can get a bit boring. Trauma, sexual abuse, and my mum abandoned me when I was 2. Marriage breakdown, stuck with a young child, no money. The death of my son. The passing of my mum and dad within 5 months. My best friend took their own life. And it's on and on. And some spiritual experiences as well. I won't read anymore, but this is several hundred quotes in this paper of people who clearly identify bad things happening in their lives, and they don't get asked about it, and it's not really acceptable. I mean, I think when we look back here at all of this in maybe 50 years' time, and we look at the science of it and the human rights, people go, what on earth were they thinking? We look back now on, I don't know, things like rotating chairs and surprise baths and lobotomies and stuff. I think it won't be too long before they look back on this period of ignoring people's lives when trying to help them and just drugging them up. We'll look back and think that was just a really bad passage of history, scientifically and ethically. But
yeah. One of the things I'd like to bring up is also this is the other quote from the Models of Madness. This is from the chapter of the work of experience-based experts, because we have so much like focus on that. If you have these kind of serious issues, you have to go to see the doctor. You have to go to just the mental health experts, and like there's no point in getting any other kind of support than the medical one. And this is one of the things that I'd like to say about this book, or this quote I took from that chapter. One of the outgrowths of the consumer survivor movement has been the development of projects and programs run by service users themselves. These take many forms, including support groups, drop-in centers, advocacy programs, housing programs, phone lines, skill teaching services, and others. These programs adhere to certain basic principles. Run and managed by people who have themselves received mental health services, based on a model of peer support rather than professional expertise, striving to minimize hierarchy and to value the contributions of every participant. And this got me thinking about a feedback I got from a psychiatric nurse a few years ago. She emailed me that she is like she was upset that I was using the term like expert by experience or person with lived experience, because I don't support the mainstream model of treating mental health. And she mentioned in her email that they like to use people with lived experience, but they have to support the treatment. And personally, I found that like quite like repulsive, or how do you say when you feel like vomiting when I was reading that, because it was such a thing to say. They like to use these people. Like it got me like quite angry to think about like using people to support the treatments. And like she was clearly giving me feedback that I should quit using the term a person with lived experience or expert by experience, because I don't support the current mental health model. And to think about these peer support or peer-led programs, it can be an issue for some people to think that these could be helpful, because these are seen as medical issues that need expertise. And like psychiatrists and these like with these on top of the hierarchy, when we consider mental health issues, that they specifically need this kind of experience or expertise, so that people can help them. And this idea of peer-led support, or someone like, for example, someone having personal experiences in hearing voices, helping other people who experience similar things, it can be quite terrifying for some people, because they are so like within this medical model, and thinking this specifically needs expertise, like professionals, trained professionals to help.
yeah,
So this is one of the things that I'd like to talk about, in addition to other alternatives that we have.
sure. So there has been a quite encouraging growth in genuine peer support. So certainly in Britain, I don't know much about what's going on in the rest of the world, but there are a lot of our NHS trusts, different areas, do have really good peer support workers embedded into the system, sometimes often managed by someone with lived experience. Yes, there's a risk that can get co-opted. People can. I'm sure there's some places that, not many that I'm aware of here, because it would get challenged pretty quickly, where they might have a preference for people who like the medical model. There's always that risk, and you see it also on Twitter as well. There's a psychiatrist there very quick to sort of run out one or two people who had been through the system or who really liked ECT, for instance, or whatever. Because look, there are some people who are experts by experience who do value medication and ECT, and they deserve a voice. But the idea that that person who wrote to you, it's fascinating. They're not embarrassed. They're acknowledging that they're censoring people they don't agree with. That's bizarre that she can say that to you and not be ashamed of it. But anyway, what I'm trying to say is there's a lot of good peer support stuff going on, and yes, there's always a risk that it can get co-opted. And the best example, probably, or one of the best examples you've already mentioned, the Hearing Voices groups, which are now, I think, in over 30, maybe 40 countries, where people who have heard voices come together without any professionals, although some voices are run jointly with a professional and a voice hearer, but in its purest form, if you like, they're run by a couple of voice hearers with no judgment, no diagnosing, obviously no medicating, where all different views about the causes are respected. So you don't have to sign up to a trauma model. You can go to a Hearing Voices, even if you believe, you've got something biological going on. And people get so many things from that. We've done some research on what people get out of those. And it's all fairly obvious. I get that it's the normalizing, the finding that there's other people like me, because there's so much shame built in by that label schizophrenia and mental illness, shame and stigma, that people tend not to tell anybody about their voice. So to be in a room with 15 other people, it's like just by itself is just completely liberating. And then they can teach one another different skills that they've used to cope, which is never taught within, very rarely taught in mental health services, learning how to live with voices, especially the scary voices. Some people can turn them off and turn them back on, tell them to come later. I know it sounds weird, but some people can do that. Everybody, if they want to just suppress the voices for a few minutes, turn the radio on or read a book. You never get taught that in mental health services, because the part of the brain that is involved in hearing voices is the speech area, brackets, because voices are an internal event, so people experience them as out there, but actually physiologically the speech area of the brain is going. And they first discovered that back in the 90s, when if you put a very sensitive microphone to the throat, even when people are hearing voices, the vocal cords are moving. It's interesting. Anyway, but the point I'm making is that peer support in its best form, like the Hearing Voices Network, is absolutely essential and and a lot cheaper. But so in Britain, quite a lot of NHS trusts are running voice hearing groups. And then when you do it within mental health services, you've got that risk again of being co-opted if you're not careful. So it's always that risk is always there. Like the recovery movement, which was this wonderful attempt to rewrite the basic philosophy behind mental, got largely co-opted around the world. But that's another story. So yeah, back to you. So
Yeah. What other alternatives do we have? How could we support people who are in these kind of extreme states or experiencing psychotic symptoms without this current medical model?
Okay, so before we get into the services that are now available, you touched on it earlier, we have scared one another off from helping one another, friends or families, with this idea that if somebody tells you you're hearing voices, you must immediately get the doctor involved. I think if someone tells you, I'm hearing a voice that tells me to kill myself or to kill somebody else, I think you do need to get some professional help, and then finding the right one is then tricky. But a lot of the time, we don't need to actually necessarily involve professional. It's just talking to people like, so is that upsetting you? What are the voices saying? Just engage with a conversation about. That's one way to express this is that we all have dreams. We all have dreams that are sometimes quite mad. When I'm saying this to 100 undergraduates, I have to say, can some of you please nod now, so I'm not the only one who's that. But then we do, don't we? And we accept that they mean something. We don't always have time to figure out what it means because we've got to get up and go to work or whatever. But everybody accepts now that our dreams, however crazy, are trying to tell us something. And that is the case for voices. So just an ordinary sort of curiosity in what the voices are saying. Would you like to talk about it? Is it scary? Is it not scary? Without always necessarily rushing for the psychiatrist or the GP, with that caveat that, you know, if it's talking about immediate threat of violence, that's a different situation. Anyway, so the sorts we have a whole range of services now. You mentioned open dialogue. It started in Lapland, I think. Is that? Oh, yeah.
Yeah.
Which is now getting embedded. There's even a couple in the States. And very quickly, the idea there, quite similar to the Mari approach in a way that I mentioned earlier. Rather than sort of focus on the individual, the task is to, as quickly as possible, get together everybody involved in that person's life with the person's permission, because there may be one or two people he or she doesn't want there for perhaps not very pleasant reasons. Who knows? But basically, I make it a group experience, and the role of the therapist is not to decide who's got what illness or who needs what pill. The role of the therapist is to facilitate everybody having their say about what the problem is, and more importantly, what the solution might be collectively. And there's good evidence of that works. Not for everybody, because nothing works for everybody. So that's an exciting development. The best research, the approach that has the most research to show it's effective is CBT for psychosis, which is a particular type of cognitive behaviour therapy, largely developed here in Britain, Manchester, by Toni Morrison's group and other people. And the goal, and if you think about it, cognitive therapy is perfectly designed for people whose thoughts may be a bit confused, disorganized, or whatever, might be believing in things that aren't really happening. It's a perfect model to help people like that. But their goal is not to get rid of the symptoms. The goal is to lower distress and increase quality of life. And very good evidence of this. This is an effective approach, regardless of whether people are on medication or not. So CBT for psychosis is clearly an evidence-based alternative or addition to medication. Then you have Soteria House approaches, which is an idea from the 70s and 80s in California, started by the very famous psychiatrist Lauren Mosier. And we heard about that in Switzerland as well. The developments around the world. There's one been running in Bern, Switzerland for many, many years. Several started in the last few years in Israel. We're still trying to get one off the ground in Britain, haven't quite got there yet. And the basic idea, in a nutshell, is that instead of sending people into hospital, you provide them with a sort of fairly ordinary house with maybe no more than six other people who are going through a difficult time, staffed not necessarily by professionals, staffed by people who are not freaked out by unusual states. What we call non-freak out ability, or what Lauren Mosier called it, the ability to be without feeling the need to fix. I mean, it's a bit more complicated than that, but very good research showing that is definitely more effective. I mean, than treatment as usual. And when you think about it, put it this way, I've always said, if and when I go crazy, do what you have to do, but do not put me in with 100 other people who have just also gone crazy that day. That is not going to help me. Maybe a few other people, because I understand I can't have my own individual, but not 100 or 200 other people. So just the culture within those inpatient units, it's impossible, however good the staff. Anyway, so Soteria House is another, we've talked about Hearing Voices Network. And then finally, the list goes on, but I will mention there is a growing sort of number of trauma-informed approaches, some using EMDR, some not using EMDR, just some doing ordinary trauma work with people who've got a diagnosis of psychosis, because the tradition has been you can't do that sort of work with these people because that's just won't work. And so that's just beginning as well. So there's a huge range of alternatives which were not there 20 years ago. So that gives me some cause for hope that things are slowly getting better.
Yeah. Okay, so as we're moving towards the end of our time together today, I'd like to ask, like, how could we create or support this positive change in this field?
Oh, that's a big one, Peter. I mean, get involved in your local area. Find some sort of group. Like check out the Hearing Voice network in your country. Think of if you're a professional, well, not even if you're an expert by experience. Look at ISPS, that organisation, which I think you might be able to put the website up.
Yeah.
Have a look at that and consider joining us in our efforts. I think we are in about 30 countries, but you can become a member internationally without, even if your country doesn't have a local branch. So yeah, it's very hard to do alone. So the trick is to find other like-minded people where you are who are either involved in some sort of local group, ISPS or Hearing Voice Network or Soteria or open dialogue. But the important thing is to find some other people. Doing it alone is just too hard, I think.
Yeah, yeah. And I'd like to remind people to get to know the book Models of Madness. I really think it's a like a treasure trove of different approaches, and I really like the amount of information that is there from these different approaches. So I really recommend people to read that. And I will put a link to this whole series to the description so people can find all the episodes. And please, if you enjoy this series, share this with your friends and let other people know that we're doing this. And our next topic will be alternatives. So alternatives to this medical model in general and alternatives for coercion. I think we also included that. So like in more general terms than this time, because we talked about alternatives for psychosis specifically, but alternatives for this medical model. And I'm excited for that episode to be able to talk about those different ways of approaching these so-called mental health problems. So thank you for being here today, John, with me again. And
Always a
I'm
pleasure. Yeah, always a pleasure.
Yeah, I'm looking forward for our next conversation. And bye, everyone.
Bye bye.